guys, colorectal surgery is easy, very easy, and colorectal surgery is so easy that most of the surgeon who does MRCS, I have seen in my college and other places, they go for colorectal surgery. It's easy. It's very easy. It's beautiful. Okay, guys, let me tell you how. First of all, you need to know the bleeding, just bleeding, and just this chart will be enough for diagnosis of colorectal disease. Just this chart, like for MRCS only, no. Like in clinical practice too, you will see everything falls in category of this chart only. And this, guys, everything you have seen in my notes, these are made by myself. Okay, collected from various books, and EMRCS is one of them. But I have seen what they gave, and then what did I do? The important one, I extracted, and I must say that there are a lot of unimportant things. That's why it's just absurd, I will say, and it's just a waste of time these days. Okay, then so bleeding, any bleeding, any bleeding in a 10-year-old boy will be juvenile polyp. Any bleeding, mark my word, listen very carefully. Any bleeding in a 10-year-old boy will be juvenile polyp. Juvenile polyp. Now, you can have a mass protruding, or you might not have a mass in your scenario. See, any painless bleeding in a 10, why am I stressing it so much? Because you confuse it with Crohn's. Guys, don't confuse it with Crohn's, because Crohn's will have abdominal pain with it. Abdominal pain. And keyword is painless bleeding. Painless means either they will tell you that it's a painless bleeding, or they might not mention pain at all. And that's the trick, guys. If pain is not mentioned, pain is not present. If pain is not mentioned, pain is not present. So any painless bleeding in a 10-year-old child is a juvenile polyp. And if with that person have abdominal pain, then it can be Crohn's. Then your first provisional diagnosis will be Crohn's. But otherwise, it's always juvenile polyp. Then, secondly, middle age or young. See, it's a 10-year-old boy and it's a middle-aged boy. If he has a painless bleeding, now, how do you say in an adult that he has a painless bleeding? So if I have pain during defecation, I will tell you that I'm feeling intense pain or I'm feeling pain. And how would I know if it's painless? I will not know that I'm bleeding through my anus. And how would I know? I take out the tissue paper and I would say, oh my God, there's some blood. Then or on the pen, I have seen patients like this. Like when I used to sit on emergency department, they used to bring pictures of this. I don't want to remember, guys. I don't like it anyway. Anyway, it's just what happens that they brought pictures of their pen, and I saw that in that pen there are blood with stool. So if the bleeding is painless, they will mention that they saw blood on pen after defecation. After defecation. And or they will tell you that in tissue paper they saw blood. So that means during defecation they didn't notice that they're bleeding because it's painless and we don't know what's coming out. Okay, so this will be hemorrhoid. Now, do you need to know the degrees of hemorrhoid? If you want to expand your knowledge, you can, but they don't ask questions from there. They don't ask at all. So you should not waste your time, because you have to work a lot in perioperative emergency and trauma. You have to waste your time there. Do various questions. I will give them, and watch the recalls classes. So why I tell you to study only these things? Because these things are short. study these things over and over again, and then when I start recalls, you watch those class, you watch those class, you must watch those class. You don't have to study anything from the recall. Nothing, nothing. You don't need anything from the recall. You just want to watch it, because you have to know how to approach the question and take the decision. That's why recalls classes are very important. Like, first important in topics class are the first important things, because like 34 in total, 34 people passed, guys. 34. Like in Bangladesh, all the coaching centers we have, just look at them. Like the coaching centers people used to look up to, that they are good, they are big coaching centers. Look at them, how many people passed. Add them all, still all of them, add them all, still the, the number is lower than me, and a lot lower. So it's just like 50% people from Bangladesh who passes MRCS passes from me, from last diet, consecutively 2 diets. Because when I first started, people didn't know me. Still, people don't know me much. Now they know me, and when they started knowing me, this happened. So all the people who passes MRCS from Bangladesh, MRCS Part A, 50% passes from me. I would say 60% and 40% from all others. Okay, so there is a thing I've always told you, this is confidence, this is not arrogance. Guys, see. So, blood on toilet paper, you don't need to know about hemorrhoids in details, like all know 1 degree, second degree, first degree, third degree. You don't need to know that. All you need to know that who gets hemorrhoid? Who gets hemorrhoid? Heavy weight lifters. Heavy weight lifters, or those who do strenuous exercise, or those who lifts weight for living, like the people who used to work in airports and ships, unloading things, loading things. All those people, they will tell you that kind of a person that came with a protrusion through anus, or something like that, something coming out, something like a small thing. So this will be a hemorrhoid. So you will get two kind of scenarios for hemorrhoid. Number one, you will get a painless bleeding. Number two, you will get a heavyweight lifter with something coming down per anus. Okay, heavyweight lifter, something, some little thing, some nodule, or some skin tag. Or what is a skin tag actually? A skin tag is just an extended area of skin. That's it. Extended area of skin. That's it. Nothing else. So these will be two cases of hemorrhoid. You will get this question. They always ask questions from hemorrhoid. Always. Always, like abdomen, upper GI, hepatobiliary, colorectal. From 1 minute. Abdomen, upper GI, hepatobiliary, colorectal. Most of the question comes from colorectal surgery. Okay. So So this will be hemorrhoids. First, diagnosis. Diagnosis is important. They ask questions from diagnosis. They ask questions from treatment. First, we know how to diagnose. Then, any painful bleeding in MRCS Part A, there will be no painful bleeding except anal fissure. That is severe pain. Except anal fissure, like in the world, even in the world, this pain is a very severe pain, guys. Even if I didn't have it, but I have seen people, like, they just don't want to defecate, they just don't want to go to washroom, it's so much painful, and they will just come. Like, I remember a joke. A man came to a doctor and said, "Doctor, I have severe pain in my anus." So doctor said, "Okay, let me check." So he opened, and then doctor wanted to look, and he said, uh, "It's just right side of the entrance." Doctor said, "Okay, so you will you will stop having this pain Just stop calling it entrance for a few weeks. Okay. So this happens, guys. So anal fissure is very painful. Anal fissure is very painful. So just a painful bright red bleeding during defecation is anal fissure. Then Then diverticulitis. It's always an old man with a dark red bleeding or dark bleeding. Always an old man with dark bleeding. Usually it subsides and with medical treatment or conservative treatment. So just give some antibiotics. You need nothing. You will always have left lower quadrant pain plus bleeding. Dark bleeding in a middle-aged or old man. That's a diverticulitis. Diverticulosis, then diverticulitis. Okay, always. Now this patient can be stable, this can be unstable. If this patient is they just ask you the diagnosis. Just remember, mostly it subsides with antibiotics and medical treatment. They will not ask you the names of the drugs, because this is not a medicine exam. This is an surgery exam. So you need to know about the surgeries. Old age, dark, brisk, large volume bleeding, left lower quadrant pain. Here, lower quadrant pain and dark red bleeding is constant. Other things, they can add things. They can add a lot of things. Okay, guys, then any large volume bleeding with an unstable patient. That patient will have dark bleeding, but that patient will be stable and you can manage it with medical treatment now, most of the time. Now, if the patient is unstable, there is no left lower quadrant pain, but severe pain, and the patient is unstable, it's vessel cause. It's a vessel cause. Just like I told you, keep my words in mind in your exam. You will see what I've said. Even if it's a long stem, it will all reflect in the stem. That they just the summary is what I said in class. The summary is what I said in class. So patient is unstable. That's a vessel cause. Remember where else I told you a vessel cause? If we have bright, forceful, sudden defecation, forceful, sudden defecation. So that and the patient gets unstable. That's a vessel cause. What's the vessel responsible? Superior mesenteric artery. That's mesenteric embolus. Okay. But in this case, large volume bleeding and no abdominal pain, that patient will have abdominal pain. Suddenly, severe abdominal pain, forceful defecation. Severe abdominal pain and forceful defecation. And the patient is just unstable. It's just his systolic blood pressure is under 90 millimeter mercury. So that will be superior mesenteric artery embolus. Okay. Then about carcinoma. Carcinoma will have other presentation in like MRCS part A. You will always have weight loss in a carcinoma, and the age will be almost above 55. 57, 58, 60, this age. Almost all, or in the 50s. In the 50s, they will always give you a scenario in the 50s in a carcinoma. Okay, rectal carcinoma or colon carcinoma, we'll talk about it later. Bleeding is not an important thing here, actually. You will get other questions from here. Then ulcerative colitis. As we are talking about bleeding, remember what I said about Crohn's disease and ulcerative colitis. In Crohn's, we will have abdominal pain as presenting complaint, mostly abdominal pain, weight loss, and of course some other associated things like um, young people, young age. Actually, the thing I want to say that rectal bleeding is not a cause here. That person can bleed later on, but Crohn's will not present with rectal bleeding. Anytime you get abdominal pain, rectal bleeding, And most of the time they mention pseudopolyp. Okay, they mention pseudopolyp and bleeding, abdominal pain, rectal bleeding, other things mentioned. We talked about it, ulcerative colitis of Crohn's in our pathology lecture. So abdominal pain with rectal bleeding, if there's no other clue, that's a young patient in MRCS Part A. It's always ulcerative colitis, and you can get mouth ulcer. So, okay, let me shorten it a little bit more. Gets a little bit wide. See, whatever they say, whatever they say, in Crohn's, we always have, of course, abdominal pain. That's common in both cases. I just can't stop mentioning it because it's so important. Fistula, fissure. Anytime they mention fistula, fissure, that is recurrent in a young patient. Young patient. Okay. Anytime they mention it, fistula, fissure in a young patient, that will be Crohn's. That will be Crohn's in MRCS Part A. That will be Crohn's definitely. Whatever they say in the stem above or below or in right side or in left side, whatever they say, that will be Crohn's. Always, always, always. And if they say rectal bleeding, young means in his 20s, 22, 25, 26. Okay, in his 20s, he will have ulcerative colitis. Remember, we all know it starts from below and goes up, and it starts as a skip lesion. So, and it spares rectum always, and it starts from below. So bleeding will be its first presentation in a lot of cases, not in every cases, but bleeding will be first, guys. Bleeding will be first. So that will be ulcerative colitis and Crohn's disease. Now, this is the basic. And what are the questions you are going to get? What are the type of questions they will ask? They will ask you from ulcerative colitis and Crohn's. Let me deal with it, then we'll go after it. From ulcerative colitis and Crohn's. From Crohn's, remember some points I tell you, just memorize it by heart. Number one, we can do segmental resection for Crohn's. Segmental resection for Crohn's. These things are specifically chosen so that you can do good in paper 2, because see, people are failing for paper 2 for last 2-3 diets. Just pay attention to what I say, guys. Pay attention to what I say. So segmental resection, we can do it for Crohn's. Number 2. But if Crohn's or any disease that is severe, okay, let us come to it later. Segmental resection, we can do it. Remember the lengths. They ask you about nutrition in a Crohn's patient. So this is my gut. Here is some problem. So absorption from these area are lost. So what do? We cut some portion from here. We cut some portion for here. Then what do? We see that how much is left. See, duodenum, let's say it's 30 centimeter, and jejunum, let's say it's maybe almost 130 or 120, 150. It varies around this area, 30 to 40, 130, 140, and ileum alone is almost 150. Okay, so total, let's say it's 120. Total 300 centimeter. After resection, if we have less than 200 centimeter left, like 190 centimeter or 150 or 70, we give this person total parental nutrition. If more than 200 left, that is 250 or 220, we give him enteral. They ask you this question, nutrition question from Crohn's, with special formula, enteral with special formula. Then if a person has a long standing Crohn's, remember guys, my this segment is lost, this segment is lost, this segment is lost, so absorption is totally a lot of absorption is hampered here and there, absorption is destroyed. So what happens, our essential amino acids and other proteins are not absorbed, and most of the time they ask you question about albumin. Albumin is a protein, our very important plasma protein formed by liver. Now, in case of long standing Crohn's, we don't get proper nutrition, and so absorption is hampered, protein absorption is hampered, and we don't get much albumin. When albumin level is low, that means your gut has failed. Your gut has failed you. So we cannot use this gut. We must give albumin. We must give total parental nutrition, because if we give enteral feeding, that person will not be able to absorb the nutrition, and that person will not be able to produce albumins and other things. Okay, so we give TPN in this case. So remember these three things I told you, and they will ask you this question. They will definitely ask you this question, guys. For 1 mark people fail, for 2 mark people fail. So don't miss a single word what I say. Don't miss a single word. I will not tell you a lot of things. I will not tell you like other people that I just don't care about other people. What do I say? People tell you that study this, study that. That's why I tell you that you don't need that, guys. Don't waste your time. Don't waste your time. You will waste your time. You will waste your money. You will fail this exam. That will be devastating. That will be very devastating. See, guys, we have ulcerative colitis. And what's the treatment for it? We have ulcerative colitis. They will give you scenarios like this. A 20-year-old man or woman, whatever you say it, trying to be gender neutral, like I identify as a man, but okay, let's just leave it. Don't other people don't those who don't identify as man or woman, pardon me, okay, because as I'm giving it internationally, so there can be some people. So anyway, 20-year-old man and woman or any other gender, as we're going to, you have to practice it. Any other gender, what happens? They came with you with rectal bleeding. Rectal bleeding. Either they will tell you this person has a history of ulcerative colitis, or this person has a history of long standing ulcerative colitis, and this is his first episode of rectal bleeding. They will tell you just like this, first episode. So for first episode, what do? You give steroids, like not anabolics but corticosteroids. You give steroids. Mostly, what do they give? Hydrocortisone. I'm not sure. Like I'm just mentioning a name, whichever works actually. I don't actually, just steroids. They give steroids. So let's say this flare goes down. This flare resolves. This flare resolves, and other case, this flare did not resolve. Resolve. If this flare resolves, send him home. Discharge. If this does not resolve over 24 hours, even if it first episode, what do? The gut that bleeds, that will kill you. The gut that bleeds, that will kill you immediately by hypovolemia. So you stop the bleeding. How? You remove the gut. The gut that bleeds, we don't need that gut. So what do? We do pan procto. We talk about it. We will talk about it. Colectomy. We do pan proctocolectomy, but this is a very big procedure and we cannot do it without an elective setting. So for this emergency, this is an emergency, guys. For this emergency case, what do? We do subtotal colectomy. We do subtotal colectomy. And then after some days, we set a date and we finish the procedure and we remove the whole gut. Because if this bleeding continues, only then we do that. But if the episode resolves and the bleeding is over, what do? We send this person back home. Then, if that person comes again with bleeding, we try to stop the bleeding. That will be our first step, but we cannot stop. Then we do this procedure, pen proctocolectomy. This will be the serial. They will ask you question in this serial, definitely in this serial, and these are the words they are going to use. They will not use words from your books. They will use these words. That what do we do? If that person goes home, that person come back again, and this happened, that happened, what do you do? So this is the serial. Okay, then angiodysplasia, you don't need that, just forget it. Investigations for rectal bleeding, all you need to know, just for your knowledge, these are just for your knowledge. What are the things we do? DRE is a prime and number one essential investigation in colorectal surgery. Anyone comes to you in colorectal surgery, stick your finger up in his ass. Now, if just remember two things from here. From DRE, you will have just two type of question. Listen very closely. Some points from DRE. They will ask you the anatomy. Let me tell you, they will ask you, stick your finger and what's posterior laterally or posteriorly. Remember puborectalis. Around we have levator ani, and levator ani is a collection of three muscles, and puborectalis is the first one. Puborectalis. Inner fissure, we all know, I just mentioned, we all know. Fissure, never do a DRE. Never stick your finger in a painful ass. Fissure, no DRE. Then another thing, a person, just these three things you need to know, just these three things. A person came to you with abdominal pain. They gave you this question just like this. Came to you with abdominal pain and is intolerant to DRE. Intolerant to DRE. Intolerant, like whenever you stick your finger up in his anus, just trying to be decent. So that person screams, "Oh my God, whatever." So that's severe pain. So that will always be an abscess. That's an abscess. That's a perianal abscess because there is no bleeding, no fissure, nothing, just abdominal pain because bleeding is not mentioned. Mark my word, guys. See the stem. If what did I say? If pain is not mentioned, no pain is there. If bleeding is not mentioned, there is no bleeding. So perianal abscess. That's the diagnosis, and the treatment will be incision and drainage. Remember, perianal abscess is a horseshoe shaped of this is the anus, and perianal abscess will be like this, and ischiorectal abscess too. It's ischiorectal abscess. It's a horseshoe shaped abscess. Other things give a reading. Then let's treatment. Juvenile polyp, polypectomy. Simple as that. They don't ask, they just ask the diagnosis. Hemorrhoids, you must know the serial. You must know the serial. If a person comes to you with a hemorrhoid, first thing you do, just tell him to eat some isfagula husk or give some stool softener. That's the first line of hemorrhoid management. Number one. But if someone comes that something protruded through his anus and now it's painful. So anytime you see something protruded, this is the P and this is the protrusion of P. So something protruded, that will be a hemorrhoid. And always you will see that will be a heavy weightlifter or weightlifter. So that will be a hemorrhoid. And as it's painful, that means it's a thrombosed hemorrhoid or strangulated. Same thing, strangulated. Let me use strangulated. That will make you remember strangulated hernia. So anytime a hernia is trapped or it came out but it cannot go back, so that will be a strangulated hernia. So if a thrombosed and acute condition hemorrhoid comes to you, you give him stool softener and give ice compression in that place. Give ice compression. Then comes the drug. First thing, GTN or diltiazem. GTN and diltiazem. What will do actually? What is a hemorrhoid actually? It's just engorged veins, right? So what will it will dilate the blood vessels and make the drainage easier of blood. They don't ask. Don't worry about it. So first thing, number one, you give GTN or diltiazem. If they ask you about treatment, remember first line is GTN. First line is GTN. Then number two, if they have a skin tag, that means GTN and diltiazem. So the hemorrhoid went back, or hemorrhoid, the pain is over, but something is protruded from the skin. That will be called a skin tag. So you can do a surgical curettage or excision. Surgical curettage or excision, you can do it. If the hemorrhoid is large, like third degree hemorrhoid that comes out and came out a long time ago and it never goes back, so you can do a hemorrhoidectomy. Okay. And the name is Milligan-Morgan hemorrhoidectomy. Just know the name. They don't usually ask this question, but these days they are asking a lot of questions. So use it. So now, why did I use this line here? See, after hemorrhoid operation, we'll use an antibiotic, right? A broad spectrum one. Antibiotic you will use according to, see, why don't I mention antibiotic name? Because according to their that hospital guideline, that's why they don't ask questions from antibiotic. They don't ask which antibiotic will you give, because every hospital has their own guideline. If you work with NHS, and the hospitals under NHS will have their specific guideline that in our hospital we will use this antibiotic for this disease, so you will use that. Just remember, with that antibiotic you add metro. That will reduce pain, that will reduce post-operative pain for hemorrhoids. Okay. Then anal fissure, what do? It's severe painful. So first thing, you stool softener plus diltiazem. That's your first line. GTN or diltiazem, first line. So first line will be, most of the time they don't ask about stool softener. You just directly get diltiazem or GTN, and then you give botulinum toxin if it does not improve. They will mention that a person had anal fissure. Then you give him GTN. He came back with pain and it did not resolve. What do you do now? You give Botox. Now, they will tell you that a person had anal fissure. You gave GTN, you gave Botox. Now, it did not improve. What do you do, my dear sir? You do lateral internal sphincterotomy. They ask this question serially, and that's the beauty about colorectal surgery. It's simple, easy, and good questions. Okay, then. Or they will tell you the first one. A person came with anal fissure. What do you give? You give GTN. Simple and easy. Now, they will tell a female came to you with anal fissure. Anal fissure. What do you give? You give GTN. It did not improve. What do you do? You give Botox. Now it still did not improve. What do? You have to do anorectal manometry first. To check if the sphincter is okay or not. To check if the external sphincter is okay. I'll not go into details because that's not important. Just remember you have to do anorectal manometry. Then if it's okay, you do lateral internal sphincterotomy. Then it is about diverticulitis, give a reading, they don't ask. Angiodysplasia, they don't ask. Give a reading. And bleeding, subtotal colectomy, then end ileostomy. Recurrent bleeding, panproctocolectomy. And about end ileostomy, I will talk about it. Whenever we do a subtotal colectomy, we have to do an end ileostomy. We will talk about it. So rectal carcinoma, okay. Rectal carcinoma. They don't ask about staging. They don't ask about anything from rectal carcinoma. They just ask about okay. They just ask about how do you proceed in a case of rectal carcinoma. Just remember this. Let me tell you. Only this you need for the exam. Guys, for your personal knowledge, every time I tell you, you can study whatever you want. A lot of things. You can study whole day, you can study whole night. I have no problem. You can get a PhD on rectal carcinoma because there are oncology and there are other things and a lot of things. But for passing this exam, just need to know whatever I tell you first. Then if you have time, you go for it. Not a problem. So rectal carcinoma, they will give you a case of rectal carcinoma. How? They will tell you a 55-year-old man came to you with weight loss, with mass in rectum. Now, most of the time, if there's a mass in rectum, the intestine will be obstructed. That person will be constipated. Intestine will be obstructed. So they will give you obstruction features. Like they can tell you that abdominal distension, vomiting, and then on biopsy, it shows rectal carcinoma. The question will be, how do you proceed? See, in case of rectal carcinoma, first thing we do, we relieve the obstruction. How? First thing, we make this double O, a loop. A loop, like we cut it here, then we make a loop. See, let me show you guys a little bit. See, let's say this is the rectum. We have an obstruction here. So all of these area will be distended and obstructed. That person will have abdominal pain, vomiting, and all that. Now, what do? We cut it here and make an opening. We cut it here and make an opening. So see this, I have bent it. So we will cut at the top of it and we'll get two openings from this tube. What will happen? This goes to rectum and this will be draining the obstruction and other fecal material. Okay, so we give the rectum some rest. How do you do it? We make a loop. This is called a loop colostomy. Colostomy, because we are doing it in colon. In transverse colon, what do we do? We make a loop. We cut here. We cut here. Let me go near. We cut here and make an opening. So one opening, it will be draining the foods from here, and we have, I don't have a pen. Okay. See, so this portion and this portion, this is coming, transverse colon, food is coming, goes out from this black area. This is the loop. We have cut it, this portion, we have cut out. So this is an open, this is a loop. And this portion is at rest. Food doesn't go down there. It just comes out through this area. So we make a loop like this and food goes out. Food goes out and rectum gets rest. After that, as rectal carcinoma is highly metastatic, highly metastatic. So give the rectum some rest and we do MRI. Why MRI? Because it goes to liver first. Goes to liver. So MRI. Then we do CT, chest, abdomen, and pelvis. Then we do, if in option, PET CT. If we have it in option, not a problem. And then we finalize the staging for occult malignancy. Okay. So CT, chest, abdomen, pelvis for metastasis. Okay, so this is the serial. Remember this. This is the ultimate serial and final serial. No exception to that. No exception. Any rectal carcinoma, they just give you stage to confuse you. No matter what the stage is, they will give you obstruction scenario, and no matter what did I say, they will give you last stages. Always, they will just mention last stages in T5, 6, 7, 8. I will show you. No worries about it. So CT, chest, abdomen, pelvis for metastasis. So after that, what will happen? So PET CT. So we do MRI, then we do CT, chest, abdomen, and pelvis. Okay, guys. So MRI, then CT, chest, abdomen, pelvis. Then we do PET CT. What do we get? We get the information about metastasis. What are the information? Two information only: present, absent. If metastasis present, you don't uh, actually you need to know, like, up to only liver metastasis, other metastasis, this thing, that thing. Those who are colorectal surgeons, they know a lot of things, and there are a lot of things. But for MRCS Part A, you don't need to know. I'll just simplify it, and you will get this question with a long stem, and the summary will follow what I said. Metastasis present, and you will see it will be a lot of metastasis here and there. So you do palliate. Palliative, there's an obstruction. You keep the loop and just let him defecate through the loop for the rest of his life. Keep the loop, it's palliative. If metastasis absent, then you will see how far it's from anal varge. How far? If it's near 10 centimeter from anal varge, like 8, 7, 9, they will give you. Or near 1 centimeter, within 1 centimeter. Okay, they will give you only 1 centimeter or near 10 centimeter. If it's within 1 centimeter, you do abdominal. We have it in here. Let me show you. We'll talk about it here. We do abdominal perineal excision of colon and rectum, because it can involve perineum soon. So we do abdominoperineal excision. And if it's near 10 centimeter, we do loop ileostomy and anterior resection. Why loop ileostomy? We'll talk about that. Just know it for now. So this is the protocol. You need to remember that if it's abdominoperineal excision, and here anterior resection, actually anterior resection, and loop just follows. Talk about it. Okay, so this is about rectal carcinoma. We have it later, I will show you. So diverticulitis classification, this very little classification, beautiful classification, simple classification, memorize it. Nothing else, memorize it. They don't ask about anything else. Remember, this is an emergency and patient die from sepsis in this case. So this is a very important situation. Then let's talk about other less important disease. Almost not important at all, but one, two things are important. Still, you need it because in colorectal surgery, it's just a little topic, short topic, but you get a lot of questions from here. So this is a microbiology question, which I have told you that anytime there is an egg and ovum in Scotch tape, two things different, guys. Egg and ovum around anus in Scotch tape is always enterobius vermicularis. Always, always. And bleeding and egg plus larva in stool. Two things are different, guys. It's amoebiasis in MRCS part A. There are differentials. There are differentials, but forget it. It's amoebiasis. You give your metro. You give your mebendazole. Remember what I say. Then, secondly, any discharge, there is nothing mentioned. There is nothing mentioned but discharge from breast, mammary fistula, like not from nipple, from around some other area. Discharge from perianal area. That's a fistula. What is a fistula? We all know it's an abnormal communication between two epithelial lined cavities. They will not ask you definition in your exam. They will tell you there is a discharge. But what is it? It is a fistula. We all know it. But in MRCS Part A, they don't give you fistula questions because there is nothing much to ask. They give you Crohn's question, always with Crohn's, always with Crohn's. And where there is fistula and abdominal pain, that's always Crohn's, always Crohn's. So what do we do in fistula? We give ceton. We give ceton. Which kind of ceton? Loose ceton. Now, do you need to know a lot about ceton? No. All you need to know that a person having Crohn's and he is having a fistula, what do? You give loose ceton. Okay. So in case of fistula, which type of fistula is most common? You don't need to know other types. Just remember intersphincteric fistula is the most common one. Just know intersphincteric fistula is the most common one. In case of acute fistula, you give antibiotic. Okay. You give antibiotic. Then if it's not associated with Crohn's, other things not important, forget it. In your MRCS Part A, only thing you need to focus on that, is it associated with Crohn's or not? Is it associated with Crohn's or not? If it's associated with Crohn's, you lay it open. If it's associated with Crohn's, and they will not, complex means Crohn's. Complex means Crohn's, and other things in MRCS Part A, complex means Crohn's. Nothing else. Complex means Crohn's. So you give a ceton. Which kind of ceton? Loose ceton. Okay, then pilonidal sinus. They ask you this question. Along your natal cleft, along your natal cleft, like where the W meets, we all know this area. If there's a discharge, it's always pilonidal sinus. We all know discharge. It's a pilonidal sinus. Okay, it's a pilonidal sinus along natal cleft and history of recurrent discharge. That's a pilonidal sinus. What do? You give antibiotic if painful. After pain settles, you do Bascom's procedure. Other not important. They don't give it. Bascom's procedure they give it in exam. Okay, then this one, perianal abscess, remember it heals by secondary incision and drainage. Then solitary rectal ulcer is not important at all, and it's most commonly they don't give it in exam, but it happens after enema, recurrent enema in an old patient. This scenario sometimes you might find. Rectal prolapse, they don't give, actually, it's an old woman always. Old woman. Old woman. Just one thing, something coming down per anus. Now, you might tell you that, bro, you have told me that something coming down per anus is a hemorrhoid, but that will be little thing, and this will be large thing. You will understand it from the scenario. We have questions. So they will tell you that it's a heavy weight lifter. This person can be a heavy weight lifter too. Okay, and rectal prolapse is a severe scenario. Okay, you will have a 60-year-old female suddenly came to emergency department with something coming down per anus. They don't give you to diagnose it. They just tell you what's the procedure you are going to do. Remember, you do Delorme's procedure. Though it has high recurrence rate, at least both has problems. Alzheimer's has anastomotic leak, so infection, that person might die for infection from infection. So it's a something. So these two are problematic, but we do rectopexy. Okay, we do rectopexy. If not possible, go for Delromes, or if they didn't mention rectopexy, go for Delromes. Okay, pardon my pronunciation. Okay, reduce it, covered sugar. They don't ask these questions. Rectal prolapse is least important question in your exam. So if you find a question, always look for hemorrhoid first. Always look for hemorrhoid first. This kind of question, almost same kind of scenarios, but seeing this will be a young patient in case of hemorrhoid, mostly young patient or middle aged or man. Women, they give women too, but mostly they give men, and it's an old woman most of the time. And they give you what's the procedure. Then remember good Sal's rule. It's a very easy rule, a very easy rule. So see, let's say this is the person's anus, and these are the legs, and you are in front. Like, let's say I am in front of the person. Okay, so I am in front of the person. So let me hold it like legs. 1 minute, guys. It's just a lithotomy position. Okay, two legs. This is the right leg. This is the left leg. So this will be 12 o'clock. This will be 6 o'clock. This will be 3 o'clock. This will be 9 o'clock. So this is the, so look in front of the camera, look in front of the camera, look in front of the picture, and let's say this patient is lying in front of you, and mark the area 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock, like this. So you see the patient. So these are the legs. This is the starting of legs. This is not full leg. So these will be 12 o'clock, 6 o'clock, 3 o'clock, 4 o'clock. Sorry, 9 o'clock. So let's say you see a fistula. That means discharge coming out from here. So we mark it around 4 o'clock, 5 o'clock, 6 o'clock, 7 o'clock, 8, then 9, 10, 11, and it's 12. We all know it. Here, let's give 1, and let's give here 2. So according to the rule, where will you find? So this is the anus, the end, not the entrance. Okay, the exit, of course. So this is the anus. So where will you find the internal opening? Because there's the connection, right? There we have the rectum, and here should be the connection like that. Where will you have the connection? Where will be the tract? That's the question. So Dr. Goodsall, he proposed this theory, and this is true. It always happens that any fistula situated from, let's say, just 3 and 9, if you find a fistula at 4 or 5 or 9 or 8 or 7, make it simple, a little bit up, I'll tell you that the opening will be along the midline, 6 o'clock. You will find the opening along 6 o'clock. And other than that, the opening will be at 90 degree. Like if 1 o'clock, 2 o'clock, 12 o'clock, 11 o'clock, 10 o'clock, the opening will be 90 degree to midline. Okay. So here we have written it, that is any fistula that is from 3 centimeter above 3 o'clock up to 9 o'clock, the tract will be along midline, that is 6 o'clock. Opening will be 6 o'clock internally, inside. And others 1, 2, 10, 11, 12, the opening will be at 90 degree. That means they will give you one option, that is you find a 6-year-old man came to you with a fistula, and you find an external opening at 4 o'clock. Where will be the internal opening? The answer will be 6 o'clock. You find an opening at 10 o'clock. Where will be the internal opening? Same thing, 90 degree. So straight tract. 10 o'clock inside. You find an opening at 7 o'clock. Where will be the internal opening? At 6 o'clock midline. You find an opening at 2 o'clock. 2 o'clock. Where will be the internal opening? 2 o'clock inside. This is Goodsall's rule. Very easy and very simple and easy question. Simple and easy question. They will just give you like this, that 11 o'clock. Where will you find the opening? You will find at 11 o'clock. It's like that. About rectal carcinoma follow-up, they don't ask this question because recently they are against surveillance. Follow-up, yes, but they don't ask this question. They don't ask these questions anymore. If you want, you can study it from here. I have embedded the link. You can have it in from Drive. Then staging for colon cancer. All you need to know that A, B, C, D. It's a very easy and simple question. All you need to know is this, that A is tumor confined to bowel wall and B is invaded, but no lymph node is involved. Most of the time they ask you that lymph node is involved, which type of Duke it is. It's Duke C. Just this question. And D for distant metastasis. Very simple. Very simple. Other things I have included it here. Just give a reading if you want. Otherwise, it's not important at all. They don't give you questions. Then treatment. Now, before treatment, These things are 100% important, collected from last exam. Very, very important. You studied. You studied. You memorize it. Whatever I told you before, I just I just gave you some isolated information which sometimes comes, but no, like no details is liver. No details is needed, guys. No details is needed. Just the lines, just these lines, just these lines, just these lines. Then about colectomies. Let me tell you about colectomies. What are the questions you will be getting from colectomies? Number one question, you will get question from cecal carcinoma or hepatic flexure mass or splenic flexure mass. Let's deal with it one by one. In case of cecal carcinoma, or they tell you that there is an obstruction and small intestine is enlarged, that means the obstruction is around cecum. Of course, normal diameter is up to 6 is good, 10 is cecum is dilated. These things are just to confuse you. Just to confuse you. All they ask that there's a mass in cecum, and what will you do? If it's they will tell you that there is a mass in cecum, you have to resect it. What will you do? Simple and easy. Right hemicolectomy. Right hemicolectomy. Number two, they will tell you we have an appendix mass, and that mass is at base of the appendix, and that is a carcinoid, pathologist told you. So anytime there is a carcinoid at the base, what do? Right hemicolectomy. Number three, you have a carcinoid at the tip of appendix, but it's 3 centimeter. That means it's more than 2 centimeter. What will you do? Of course, right hemicolectomy. Write it down. Don't trust your brain, guys. Don't trust your brain. Number four, they tell you that there is a mass in your ascending colon, and everything before it is dilated. What do? And biopsy shows it's a carcinoma with no metastasis. What do you do? Right hemicolectomy. And finally, a carcinoma at hepatic flexure. Hepatic. Sorry, guys, it's hepatic. Hepatic flexure. That means right colic flexure, a carcinoma. What do? Right hemicolectomy. And remember, every time you do right hemicolectomy, any right-sided hemicolectomy, you do anastomosis. Immediate anastomosis. No need to lay it open or do anything. Immediate anastomosis, because its failure rate is very low. And you use that person's gut. Tell them to eat as soon as they wake up. As soon as they wake up, you give them a chewing gum. As soon as they wake up, then you give them to eat. Of course, liquid. Start with liquids. Then you early mobilization of the patient will reduce the risk of thrombosis. Early mobilization. Then you tell them to walk at least 3-4 hours or sit the next day. Then forget it. I'm just using this. Okay, carcinoma of splenic flexure. If we have a carcinoma at splenic flexure, what do? We do extended right hemicolectomy. Just do extended right hemicolectomy. You don't need to know about other diseases. Only the things I tell you. Only these things. Other things not important at all. Not needed at all. Just forget those. Just forget those. You will pass this exam very easily. Carcinoma of splenic flexure. You do extended right hemicolectomy. Extended right hemicolectomy and anastomosis. And what will be the anastomosis? See, we cut from here up to here. So we do ileum. So ileo colic, colon from here. So ileocolic anastomosis or ileocolic anastomosis, whatever you say it, however you say it. So this is the thing you must know, that in case of any right-sided carcinoma, you immediately do right hemicolectomy and join this portion with this portion, that is ileocolic anastomosis. Ileocolic anastomosis. Now, if you have due to some reason you have diverticulosis or diverticulitis and the bleeding does not stop, bleeding does not stop, what did I say? If some bleed, if you can't control the bleeding, you resect that portion. Like surgery is easy, guys. Whatever we can't control, we resect it. Just cut it off, forget it, you don't need that anymore. 1 minute, guys. So surgery is easy and surgery is beautiful, guys. So what do? You um resect it. Whatever you don't understand or you can't control, you resect it. You just get rid of it. So what do? We call it Hartmann's procedure. As it's an emergency, we can't control the bleeding. We do Hartmann's. What is Hartmann's? We cut from here up to here, the portion that's causing diverticular bleeding. From here, mostly left side, okay, mostly we say sigmoid. Mostly we cut sigmoid colon. So sigmoid colectomy. We do sigmoid colectomy. Remember, in case of left-sided problems, we can't anastomose it because there is rectum and there are bacteria. Failure rate is very high. Almost all of the anastomosis fails in case of left colon. Okay, so we do sigmoid colectomy. See, here we have the picture. We do sigmoid colectomy. Now, see, after doing sigmoid colectomy, this portion is gone. So the food we eat, where does it come out from? We make an opening here. Opening is called a stoma or mouth. Opening is called a stoma. So this stoma is from descending colon. Descending. This stoma is from descending colon. So it will be called colostomy. This is a stoma from colon. This is an opening from colon. So this will be called colostomy. So what did we actually do? We did sigmoid colectomy with descending. We don't need descending, colostomy. Now, this is the end. This is the end. We did not keep any relation to rectum. Rectum is just as it is there. Okay, so this is the end. So this colostomy, this is the end, and it will be like it. If we do something later, like we can't really do it actually in practical scenarios. This is very tough, and this is never done actually because maybe no one ever tried. I don't know. So I have to learn a lot for that. I just love it. Anyway, then what happens? What happens that this is the end. Food comes out through here. We attach a bag on this patient and we tell them to take good care of the stomach. So it will be an end colostomy. This is the end. There is no connection with rectum anymore. So this is the end. This is called Hartmann's procedure. Hartmann's. This procedure is Hartmann's procedure. So this procedure is Hartmann's procedure. What is that? Sigmoid colectomy with end colostomy. End colostomy. Okay, guys. Then what do we need to talk about? Almost all of the things have talked about. And subtotal colectomy. Subtotal colectomy I have told you. And pan proctocolectomy is this one. This is extended right hemicolectomy. We can extend it up to splenic flexion. Okay, so okay, let's talk about loop a little bit. What is a loop actually? So what is an end? What is a loop? See, if we do this is panproctocolectomy, guys. Here maybe they spared rectum. Yes, here they spared rectum. So this is panproctocolectomy. So see, what's end and what's loop, guys? We cut this portion. So this is the end, and this is from colon. So end colostomy, because there is nothing left. So wherever end is written, that means after that all of it we have resected. So if we do panproctocolectomy, like all of the colon plus rectum, we have cut it out. What will be left? Food will come through your stomach, go to jejunum, ileum, and then come out through ileum. This place will be taken out and a bag will be attached. So ileum, and this is the stoma. This stoma is from ileum, so we call it ileostomy. And this is the end, nothing left after that, nothing left. So it will be end ileostomy. End ileostomy. So if they attach end ileostomy with panproctocolectomy, that will not be a wrong answer. End ileostomy. End ileostomy. So panproctocolectomy with end ileostomy. And what is a loop? The thing we do in rectal carcinoma. What do? We cut it here. So we get two openings here. So this opening, so here food comes and comes out through this, and this is the rest portion. This is the rest portion. If we need it, we keep it. If we don't need it, again we just stitch it and fuse it. So loop, we can reverse it. So this is the loop, and it's a stoma, and it's from colon, so it's called colostomy. And what kind of colostomy? End or loop? It's a loop, because we have kept things after that. We have kept the connection, so we can use it if we need. And end means there is no use. This is the end, and we will resect it, and there is no hope. So this is the end. Nutrition, I have talked about it. Now other things, complications of a stoma, just give a reading. They don't ask anything. Just remember that anytime if they say there are some streaks around the stoma, that will be pyoderma gangrenosum. Pyoderma gangrenosum. Anytime they say that stoma length is increased, whatever they say, up, above, below, right side, left side, don't worry about it. It is increased. That's prolapse of the stoma. Stoma prolapse. Okay, just remember these things. Other things we have given it. Don't worry about it. Remember, here we have it. Here we have it. Then output, high output stoma. Guys, about high output stoma. See, where do I do a stoma? We do it in intestine. Intestine. So if a stoma is a high output stoma, what happens? It will be a lot of secretions will coming out from stoma. It's defined by 1500 ml per day, more than 1500 ml per day. So intestinal secretion is rich in potassium bicarbonate. So when we have a high output stoma, we will have hypokalemia. We will have acidosis, because we are losing bicarb. Acidosis. And remember, chloride from blood is uptaken in exchange of bicarb. Now we don't have bicarb, we have low bicarb. So what happens? Chloride will remain in blood. So we can have hyperchloremia. From high output stoma, they just ask you metabolic abnormality. Just metabolic abnormality. Okay, metabolic abnormality. Again, in case of urostomy, we resect or cut out some portion of the jejunum or ileum ileal conduit, so ileum. So this portion, this portion that was secreting HCO3 bicarbonate, that amount of bicarbonate is low, so that amount of chloride will be increased. Okay, so remember these things, just these things, and give reading to these things. Some scenario we have attached the answer, but first you have to you try to answer it by yourself. That's how your our abdomen, colorectal, all these things. And hope you enjoyed the class, guys. And remember always, everything I told you will come in your exam. Everything I told you mentioned, these are very high yield and most important things, and these are very common things, and this is a cut mark exam. If you answer this correctly, no matter how hard the question is, you will always pass this exam. Always. Like recently questions are being so hard, that means there is no alternative to me, because I am giving you all the precise things you need to pass, and I have proven it in my results. Thank you, guys.